Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
Thank you all for joining us for today's podcast titled Casper-2, Iglon-5, and Ma2, The Weird World of Sleep in Autoimmune Encephalopathies, Part 1. Autoimmune and paraneoplastic disorders affecting the nervous system affect multiple neural systems, including the brain, responsible for sleep and wakefulness. Although rare, the sleep manifestations can be dramatic, and both neurologists and sleep specialists should be aware of these syndromes, as occasionally such patients will present to them. To discuss the weird world of sleep in autoimmune encephalopathies, my guests today are Dr. Michael Silber and Dr. Eric St. Louis, both professors of neurology and board-certified sleep specialists at Mayo Clinic in Rochester, Minnesota. Mike, thanks so much for being here today, and Eric as well. But Mike, let us begin with a brief overview of these disorders and how they are classified.
Thank you, Maitri. These are not common disorders, but they do come up, and a remarkable number of them have got sleep manifestations, and so sleep specialists and practitioners should be aware of them. They're also very interesting conditions with sometimes unusual manifestations. So we can classify autoimmune diseases affecting the nervous system in various ways. The first is whether they are idiopathic autoimmune disorders or paraneoplastic, in other words, associated with a tumor. And examples would be diseases associated with tumors such as thymomas or carcinomas of the lung or other organs, in which case the immune response is triggered by antigens in the tumor, which mimic antigens in the nervous system, either the central peripheral nervous system, whereas the autoimmune idiopathic ones, it's not clear it's an autoimmune disorder. There's no underlying neoplasm, but again, some sort of abnormal antibody response is attacking areas of the nervous system. The other way of looking at it is whether the antigens that are being attacked by the antibodies are cell surface antigens or antigens within the neurons themselves. The cell surface ones generally are proteins which deal with channels across membranes, for instance, conductivity of nerves along the surface of the neurons, whereas the intraneuronal ones are really attacks against structural parts of the neurons. This distinction is important because the surface ones, generally the effect of the immune response is to interfere with function, with conduction of nerve impulses or transmission across a synapse, whereas the intraneuronal ones, that's really often destruction of the neurons themselves. And as you can extrapolate from that, the surface antigens, those immune responses are often very, very susceptible to immunosuppression, and we get very nice results by immunosuppression, whereas regrettably the ones which attack neurons themselves, often with destructive properties, they aren't as responsive to immunosuppression. So examples of a cell surface autoimmune process would be myasthenia gravis, for instance, where your antigen is against the acetylcholine receptor on postsynaptic peripheral nerves. That's not associated with sleep disturbances per se. And an example of one buried within a neuron might be anti-Purkinje cell antibodies, which cause severe cerebellar dysfunction and are usually paraneoplastic, often associated with carcinomas of the ovary. And those processes are very unresponsive to immunosuppression, regrettably, and by the time the diagnosis is reached, often there's severe destruction of cerebellar neurons, the Purkinje cells. So that's sort of an overview of these disorders, and we'll be happy to discuss some of the ones that are more more associated with sleep disorders.
Thank you for that overview, Mike. Perhaps we should start with Morvan syndrome. Could you tell us about your first patient that you saw with this unusual disorder?
Well, this was way back, 1992. I was asked to see a patient who'd been admitted with a severe neurologic disorder that nobody seemed to be able to work out what it was. And this patient had had for several months severe burning feet. So severe, he'd gone out in the snow in Minnesota and stood in the snow to try get relief. And as the disease progressed, he noticed he was having twitching of the muscles of the arms and legs, painless twitching. And then he had strange spells when he would perspire profusely. His blood pressure went up, he would hyperventilate, and in a few minutes it would all settle. And then, as all this evolved, he developed insomnia, profound insomnia, to the point in which he and his wife really didn't think he was sleeping at all. At night, he would be somewhat confused, hallucinating, but he seemed to be awake, and it was really quite difficult over 24 hours to work out whether he was awake or asleep. In fact, EEGs suggested that he was having theta rhythms, slow rhythms much of the time, but really without any sleep manifestations such as spindles or K complexes, and nothing to definitely suggest episodes of REM sleep, though at times there might be some rapid eye movements intruding into what didn't look otherwise like REM sleep. He also started jerking during the night, little twitches and jerks of his arms and legs. So he was otherwise a healthy middle-aged man. His only other illness was hypothyroidism, which had been well treated. Well, when I saw him, the combination of this muscle twitching and profound insomnia led me to suspect he might have Morvan syndrome. And an EMG was very, very abnormal. For those of our listeners who work with EMGs, the nerve conduction studies showed repetitive discharges instead of just a single motor unit potential. There were after discharges of 2 or 3 motor unit potentials. And on needle examination, he had profound neuromyotonia and myokymia in almost every muscle tested. And this combination of peripheral neuromuscular hyperexcitability and this profound insomnia are the characteristic features of Morvan syndrome, described for the first time in the 19th century. Nobody had any idea what caused this. There were strange hypotheses such as heavy metal poisoning, such as gold toxicity. Our patient had no evidence of heavy metal toxicity, and we had no idea what caused this. We tried multiple hypnotics with no success at all, and then stumbled on opioids. And when we put him on quite high dose opioids, he fell asleep at last and got some sleep. And then he slowly started spontaneously recovering. And as he recovered, we did multiple sleep studies. He developed REM sleep again, and this was clearly REM sleep without atonia, with increased muscle activity during REM sleep. And then with time, he fully recovered. Everything went away. Years later, it was discovered, not at Mayo, but elsewhere, that Morvan syndrome is an autoimmune neurologic disease caused by what was then called potassium channel antibodies. And we'd kept his serum. And we tested his serum perhaps a decade later, and his titer of potassium channel antibodies was in the sky. So he had an autoimmune disorder which spontaneously recovered. And of course, in retrospect, we should have guessed that may have been it, because his only other disease was autoimmune hypothyroidism. But we didn't stumble on that. So that's my introduction to that, the story of a very typical case.
Truly a fascinating case, Mike. Thank you for sharing that. So, based upon this experience and subsequent patients that you have seen, could you give us maybe a broad overview of what clinical features to expect, how to manage this, and maybe a little bit about the related conditions as well?
Yes, a very, very interesting condition. Well, let me start by saying today we subdivide the potassium channel antibodies into at least two types. There is a third one we'll come back to later, but the two are today called Caspr-2, CASPR-2 antibodies and LGI1 antibodies. The Caspr-2 antibodies are actually not against the potassium channels at all, but against proteins in the paranodes of the neuron. And LCGI antibodies are against synaptic proteins, so it's not really potassium channels specifically. Most patients with Morvan syndrome have Caspr-2 antibodies, but a minority have the LGI1 antibodies, and some have both. The clinical features of Morvan, or let's say the clinical features of Caspr-2 antibody disease, would include the typical Morvan syndrome, but also some people get just the peripheral manifestations, this peripheral nerve hyperexcitability, in which case it's called Isaac's syndrome, actually described after a neuromuscular physician in South Africa many years ago, Dr. Isaacs, who first described it. Again, we had no idea it was autoimmune back then. So the patients present generally with the hyperexcitability, some small fiber neuropathy changes, these burning feet, spells of autonomic dysfunction, like our patients with this sudden sweating, hypertension, uncertain whether these are autonomic seizures, what exactly those might be, but then the profound encephalopathy with the insomnia and this acting out of dreams. It's sometimes called the acting out of dreams with the name agrypnia excitata, which is simply confused acting out of dreams. The other name given for it is oniric stupor, dreamlike stupor. Very strange, very odd. The PSGs show slow rhythms, sometimes intrusion of rapid eye movements, but with increased muscle activity. And as I explained, as they recover, sometimes more typical REM sleep evolves with loss of REM atonia. The MRIs are normal. It doesn't help you. CSF examination may show the antibodies as well as in the serum, but usually there isn't a pleocytosis. Now, the Morvan syndrome can be idiopathic autoimmune, as I described, or it can be paraneoplastic, and it can be associated with thymomas, most typically, or sometimes small cell lung cancer. The second patient I saw a few years after the first had a thymoma and was otherwise very typical, but his was paraneoplastic. I say he because, for reasons we don't understand, there is a very strong male predominance in Morvan syndrome, extremely strong, and that's not quite clear why that is so. Because these are surface antigens, they actually, the condition responds very nicely to immunosuppression, and various types of immunosuppression is used by neuroimmunologists to try control the condition. Obviously, if there's a tumor, you need to resect the tumor, but the prognosis is not bad at all. Some of the autoimmune groups may have hypothyroidism or unrelated, actually, myasthenia gravis has been reported together with Morvan syndrome. So that's an overview of what's really rare, but a very fascinating condition, and one doesn't want to miss it.
Now, there are a few other rare autoimmune brain diseases or conditions with antibodies against the cell surface antigens that can occasionally manifest with sleep problems. Could you tell us briefly about some of these as well, Mike?
Yes, let me briefly talk about two of them. The one, the antibodies against DPPX, which is another cell surface antigen, which has multiple manifestations, including GI manifestations and neurologic peripheral and central nervous system manifestations. But these patients may sometimes present with REM sleep behavior disorder, acting out dreams, sometimes with insomnia, and with sleep apnea, which is interesting, and exactly what the mechanism there is unclear. The other one I just want to mention is the very strange condition of NMDA antibody disease. NMDA is a form of glutamate receptors. I mean, they're normal receptors, extremely common through the whole brain, and sometimes one develops an antibody attack on these receptors. The patients are usually children or young adults who, in this case, more often women than men. Very interesting, the gender relationships. And they present with psychoses. And initially, they're thought to have a primary psychiatric disorder, an age group where schizophrenia develops. One worries about drug-induced psychoses, but this is a neurologic organic psychosis. Then they sometimes have seizures, and that gives you a clue that it may not be just a psychiatric disorder. And then they also develop sometimes profound insomnia, rather like Morvan. And interestingly, there are reports that as they recover with immunosuppression, it moves into a phase of hypersomnia. I should just mention, I guess, lastly, we talked about Morvan and mainly Caspar-2 antibodies. What I didn't describe was the opposite side of the potassium spectrum, which is the LGI1 antibodies, which present generally with something rather different, which is limbic encephalitis. And on MRI, the temporal lobes light up with increased T2 signal. There's usually a pleocytosis, and they present more with seizures, which you can imagine from temporal lobe involvement. That would be common, and memory loss from temporal lobe, hippocampal involvement. It They can merge into Morvan. Some of them also have insomnia. But most often it presents more with that typical limbic encephalitis picture. So there are three other examples of cell surface antigen antibody reactions with some sleep manifestations.
So let us now consider a syndrome in which the antibodies are directed against antigens within the neuron itself, as opposed to on the cell surface, which we've discussed up until now, specifically MA2 antibody syndrome. Eric, I know you've had some experience with this disorder. How can this present to a sleep specialist, and what would lead you to suspect this disorder, and what are some of the associated conditions?
Three, thank you very much for having me today. And anti-MA2 antibody syndrome is another often usually paraneoplastic, but sometimes idiopathic neurological sleep disorder that will frequently present to sleep specialists, especially neurologists. And what it looks like is typically severe and relatively subacute or rapid onset narcolepsy. Patients tend to have especially prominent hypersomnolence or excessive daytime sleepiness, and this seems due to the predilection of this antibody syndrome to affect the hypothalamus and the brainstem regions that regulate sleep-wake. It's commonly associated with testicular tumors and germ cell tumors in younger men, but it may be associated with lung cancer in older individuals when it is presenting as a perineoplastic syndrome. So the narcolepsy of this looks different and is often refractory to treatment. Different in that especially it may present in a more subacute fashion, coming on rapidly over a time course of weeks or months rather than years. Often the company it keeps looks different. And as Mike was saying, sometimes these patients present with a syndrome, not only of sleep disturbances, but with other complex neurological findings. So a careful and tailored neurological exam to look for particularly brainstem type abnormalities, things like vertical gaze paresis, ptosis, or diplopia can be seen on physical examination. And oftentimes patients may have cognitive impairment or short-term memory impairment. As anti-MA2, while it affects the brainstem and hypothalamus, especially can also have a secondary limbic encephalitis or component of involvement of the mesial temporal lobes, where sometimes it can even trigger epileptic seizures and drug-resistant seizures. I saw a case recently that presented to me in the epilepsy clinic and not the sleep clinic, where I detected narcolepsy more on the side as a secondary manifestation of this particular patient's syndrome. So sometimes these things can present heterogeneously to different specialists. When working up these patients, the diagnostic testing should include brain imaging, often but not always, because there can be neuronal destruction with these antibody targets. We might see hyperintense T2 flare signal or other abnormalities in the vicinity of the hypothalamus and the medial temporal lobes, and especially around the area or vicinity of the third ventricle. If spinal fluid is checked, and often it should be in this syndrome, if you don't find the antibody in the serum, it should be tested also in the CSF. But many times in a patient with this disorder, both serum and CSF may be positive for anti-MA2 antibody, which should be sought selectively when patients present in this fashion. And another key finding in CSF is one will often find lower undetectable levels of CSF hypocretin or orexin in the spinal fluid, indicating this destructive process of hypocretinergic neurons in the posterior lateral hypothalamus. One may also see inflammatory change with high protein pleocytosis or even oligoclonal bands in the spinal fluid. And, one should really seek a paraneoplastic type disorder in these patients specifically. At least 70% of these cases are associated with an underlying malignancy, especially in the younger men. And again, testicular or germ cell tumors in younger men should particularly be sought with testicular ultrasound or other specific evaluation of such patients. In the older patient with the similar syndrome, one must think of either non-small cell lung cancer or a variety of other tumor types. In women, breast cancer has been reported to do this. A spectrum of other carcinomas and other cancers can cause it. But when no malignancy is detected, this can also be an idiopathic disorder, in which case it often involves the limbic structures, as in the case I mentioned, a bit more prominently.
Eric, am I correct that they may have cataplexy, just like ordinary cataplexy, and REM sleep
Indeed.
behavior disorder sometimes as part
Indeed.
of narcolepsy?
Indeed, they don't all have cataplexy, but because of this involvement of the hypothalamus and destructive involvement there, they often do have cataplexy, which can be sometimes treatment refractory, and a spectrum of parasomnias, but particularly REM sleep behavior disorder might also be seen in this condition in some cases, or sometimes, as in the case I saw recently, no clinical dream enactment, but the signature of REM sleep atonia loss or REM sleep without atonia on the polysomnogram. So those definitely can be part of the overall presentation.
So once the diagnosis has been established, then, Eric, how does one go about treating this condition, and what is the prognosis like?
Yes, well, oftentimes the treatment, particularly in paraneoplastic settings, should be particularly focused on aggressive cancer treatment as directed by the treating oncology team. This, of course, would include tumor removal, chemotherapy, radiation, biological therapies, or whatever tailored oncologic therapies may be indicated. But this can also be an opportunity for immunotherapy, often starting with high-dose corticosteroids with pulsed IV methylprednisolone, Solu-Medrol, for example. If they don't respond to that, then early courses of either IVIG or plasma exchange have both intermittently been described as successful, and sometimes other therapies such as Rituxan can be offered. And in terms of prognosis, overall, the literature might suggest a poor prognosis for complete recovery. The importance of early immunotherapy and aggressive cancer care can't be overstated, because up to a third of patients might see some improvement of their neurological and sleep disturbance syndromes, whereas about another estimated 20 to 40% at least show stabilization. And they might have chronic persistent sleep disturbances, particularly hypersomnolence or cataplexy, but they may then have a better chance of responding to typical symptomatic therapies from a sleep medicine and sleep neurologic perspective.
Mike and Eric, thank you so much for sharing your expertise today. And to our listeners, for joining us today. In the next podcast, we will continue our discussion of autoimmune disorders and sleep, especially focusing on the strange condition of anti-Iglon-5 disease.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.